we are broadcasting live.
Okay, thank you, Andrew. Welcome, everyone, to our second town hall meeting done by virtual technology. So as always, we're a little bit nervous about whether or not we're going to still all be here by the end of the 2 hours, but we'll forge ahead. So welcome to anybody who's signed on and anyone who has submitted questions for us to try to inform our residents of what's going on. So I will be the moderator tonight with our presenters from Wellington-Dufferin-Guelph Public Health Unit. Chris Beveridge is the COVID Incident Commander. And also we have Dr. Matthew Tenenbaum, Associate Medical Officer of Health with the Public Health Unit. So thank you, gentlemen, for attending tonight. And how we're going to work is both Chris and Matthew will provide us with some overview, and then I will ask some sort of general questions just to make sure that we are all hearing the same information. Thank you to Ralph and other members of council that have put this together. And if there's anything that we're missing and we have time to answer any further questions, we'll open it to the floor. So let you start us off, Chris.
Okay, well, thank you. And if I have a little presentation to show everyone.
Sounds good.
I'm just waiting for it to be brought up onto the screen. There we go. Okay, so thanks again. So tonight, Dr. Tenenbaum and I will just give you updates regarding COVID-19 in terms of what we're seeing in terms of cases and also some vaccine information as well. So if we go to the next slide, this slide represents Dufferin County cases over time, indicating the 3 waves that we've experienced. The first wave a year ago, and that's that first blip, May 2020, followed by our second wave, January 2021, and then our third wave that we're in now and we're coming out of in that downward trend. So this really shows that each successive wave hits a community a little bit harder and a little bit quicker each time it presents itself. And so you can almost time it exactly, the 2 weeks post, say, provincial lockdown, or 2 weeks post provincial relaxing of the public health measures, based on the distribution in the cases that we see over time. So this is what we use to determine what a wave is, when a wave is happening, and then in this case, in the third wave coming into May, that third wave lessening its impact as we are now experiencing the positive effect of things like public health measures and increased vaccination within the community, indicating less rates of disease and less transmission in the community. So that just shows you graphically what the waves look like. And if we go to the next slide, this is really showing the differences in our cases by age, again, over time. The orange bar graph are the cases that we experienced before 2021, and the purple bar graph is the cases that we've experienced this year so far. And they're quite opposite. So if you look at the 2020 numbers, most of our cases were in the older age group within the community, in the 80 plus and the 60 plus, et cetera. And now in 2021, we're seeing the opposite of less 80 plus cases and more in the 40s, 20s, and even in our children age categories. So this is indicative of 2 things. I'd say the first is the variant of concern appeared in the province in the new year, and also our vaccination campaign in getting our older population vaccinated right away as soon as we got the vaccine in January. Unvaccinated population this year, combined with a variant of concern coming into the province, we're seeing higher rates in our middle-aged and younger age cohorts. Vaccination, we're seeing less cases within our older population because we're getting good uptake on the vaccine. So it's just showing the effectiveness of the vaccine over time as those age differences shift, but also the impact of the variants of concern in the community. And that's really evident when we look at the next slide and the variants of concern over time and how they've really predominated the COVID picture in terms of our cases. So most of our variants of concern are the UK variant, or otherwise known as the B117, followed by the Brazilian variant. But most are in the UK, or others just have not been determined which strain, if I can say it that way, have been identified. But we see early on in February the VOC starting to take hold in our cases, and then it becomes a more predominant type of COVID in the community because of its transmissibility, or it's easier to transmit from one person to another, whether it be through lack of precautions, or it's easier to transmit because it's a little stickier and easier to latch onto mucous membranes than sort of, I guess we could call it COVID classic or COVID Mark 1 perhaps, but the non-variant of concern. So we see an increased transmission rate with the variants of concern, and this is what we're seeing in this graph. Is come April, we really saw a big increase in our variants of concern, and we continue to see them, although the main bar looks a little small, but we're only at the 6th day in May, so we need to give it a bit of time to identify more cases as the month goes on. One of the challenges with the variants of concern is, like I said, the increase in transmissibility of it, and also the ability to create severe illness in those that it infects. So right now, our intensive care units in our hospitals are experiencing that now, but with a younger patient. So we've seen in the news, and we may know people or know of stories of people working in the hospitals that have experienced some tragedies and tragic losses within families. And that's really due to the infectiousness of the variant of concern that we're being presented with right now within the community. So most of our intensive care occupancy is around 83%. And in some cases, our overflow for ICU has been maximized, and that's certainly what we're seeing within the GTA. And it's closer to home too. This is not just a Toronto issue; it's a provincial issue, and there's not one community in the province that's been left untouched or unscarred from COVID, and its tragic stories that are coming out of it. So the best way right now to manage and reduce cases from these variants of concern is the continuation of our public health measures, so masks and hand washing and physical distancing, adhering to that stay-at-home order, having meetings such as this and remotely, as sort of inhuman as it may seem, because we're social and we want to be together, but this is the way that we're going to beat the transmission of variants of concern. In combination also with our vaccination campaign. So our vaccination campaign has been on the go since January, and it's becoming more aggressive each week as we get more vaccines into the province and into the local area to be able to provide it in our clinics. So our next slide shows our allocations of vaccine into the Wellington-Dufferin-Guelph area, focusing on Pfizer. And we need to also keep in mind that our vaccination campaign and all of our clinic capacity is based on our ability as a health unit and the health unit area to provide 10,000 doses of vaccine a day, or 70,000 doses a week. So when you look at our allotments, for most of April, we only received 7,020 doses a week, far below our 70,000 capacity to administer. Starting last week, it's still this week, May 3rd, we received an increase to 9,360 doses, and we'll get the same shipment next week on May 10th. Now, to finish off the last 2 weeks in May, we'll be getting 12,870 doses each week. And that's certainly a good step forward and a welcome increase in our vaccine shipment. We also have to keep in mind we do have that capacity to do 70,000 doses a week, which is very different than what we're getting. And that's happening across the province as well. A lot of capacity to deliver vaccine. We just need more product to be able to provide people and vaccinate them. On the Moderna front, our Moderna shipments have been reduced, and I don't have any line of sight on next shipments of Moderna into the Wellington-Dufferin-Guelph area, so that's why the slide ends on April 24th. And AstraZeneca, we had good uptake with AstraZeneca with our local pharmacies and primary care and family physicians, but that too is running on low supply, and I don't have any information on the next shipments we get for AstraZeneca into the area. So right now, all of our clinical applications for immunizing people are being held within Pfizer, and the doses that were, and the increased doses, I should add, so with Pfizer into our clinics. And we've got three main vaccination sites within Dufferin County. We've got the Alder Rec Center in Orangeville, and we've got the Mel Lloyd Center in Shelburne, and the Grand Valley Community Center, of course, in Grand Valley. So three main hubs in Dufferin, and we also look at pop-up opportunities based on risk or low vaccine uptake or other social determinants of health that may require a pop-up clinic in a particular area. But our main hub sites within Dufferin are these three locations in Orangeville, Shelburne, and Grand Valley. And I don't have any information on June shipments, although it's been talked about that we could see an increase going into June. And it's my hope is that we'll be at least see a doubling of these numbers to vaccinate even more people into June. And that should put us on track to really get some second doses on the go, because that's been delayed up to the 14, or rather 16 weeks, the 4 months, and get the second dose regimen completed as well. So we'll stay tuned on what we get for June, but this is what we're working with for May. And the entire approach for our vaccine campaign is whatever we receive 1 week, we'll use it up by the end of the week. And then we get our next shipment on the Monday, and we use up that on the Monday. So no vaccine is left sitting in the fridge or the freezer, and nothing is being wasted. So if someone forgets their appointment and they don't show for their shot, that particular vaccine is then earmarked for I call it our last call list, and we'll start phoning people who are on standby to come into the clinic and get that shot, because no shot is wasted from a no-show or a forgotten appointment. And initially in our phase 1 campaign, as we were vaccinating long-term care workers or healthcare workers, those vaccines were earmarked for first responders such as police, fire, EMS workers. Now that we're into our phase 2, we have essential workers on standby who've, rather than getting it a week from now, they can come in on the last call list and get it today. Keeping in mind the best vaccine you can get is the one you can get today, regardless of the product. The benefit of the vaccine certainly outweighs any risk that there may be associated with a vaccine. So with that in mind, our next slide is how to register for a COVID shot. Oh, I'm sorry, I skipped one. Did I skip one or did we skip one?
Yeah, that's right.
Okay, so who's been vaccinated to date? As we can see here, our goal is to vaccinate 75% of the eligible population. So at the time of this writing, eligible population was anybody over the age of 16. That was changed late yesterday because Pfizer announced it can be now administered to anyone 12 and over. So 12, 13, 14, 15, and 16 as well, plus our usual ages that we've been vaccinating. So this is a little off, and this just also speaks to the changing nature of the environment and we're working in, where one day we're expecting one thing, and then the next day it's announced that it's something else. So always a state of change, and we're trying to keep up with the latest and greatest information coming out of Health Canada and the province and the Ministry of Health and other public health and agencies as well. But this graph really shows the success we've had in our vaccination campaign by age, where 80 plus populations are at least 95% vaccinated. And I think that's gone up as of today. It's now 96, 75, 91%, in the 70s, 86, and so on. So these are the ages that we've been able to vaccinate. We're moving into our 50+ vaccinations and essential workers, and also all essential workers, regardless of age, are being invited into our clinics. So we'll see these age percentages increase over time because we're actually getting younger people now into our clinics. So just a good visual to see where we are in terms of achieving our goal of 75%, and all indications so far that we'll exceed that based on what we've seen with the other age groups getting vaccinated. So our next slide is, this is the one where to register for a clinic. 3 ways, although probably may be changing in the near future with the lack of AstraZeneca coming in, unless we get another product into our pharmacies relatively quickly. But 3 ways to get vaccinated. One is at our public health-led clinics. So those are the 3 clinics in Dufferin and Shelburne, Orangeville, and Grand Valley. But also we have clinics in Fergus, and we have other pop-up clinics happening in Wellington County, and also clinics in the city of Guelph if someone's want to go for a little trip and go to other locations such as Fergus or Guelph. But public health clinics, we also have the pharmacy route. Currently, people over 40 to get a vaccine at the pharmacy, or of course your own healthcare provider at your family physician office. And everybody in the region is encouraged to book an appointment for a vaccine where you can get it as soon as possible. So right now our registration line is open right now from anybody 12+, based on the announcement the other day from Health Canada. So everybody right now in the Wellington-Dufferin-Guelph area, regardless where you work, where you go to school, what you do, as long as you're 12 and older, you're eligible to register for a vaccine. So I've registered my daughter, who's 13, to get her shot. It probably will be a while until that happens. We've got to get the essential workers done. But she's in the system, and when she is eligible, based on availability and slots to book an appointment, she'll get vaccinated. So the next slide is really just a continuation of this one. And it just shows the routes in which to register, both at the website at the health unit, the pharmacy system and their booking website, or also calling your primary care provider. All the instructions on how to register are on the health unit website at the links indicated on the screen. And also we have an appointment site to get the most up-to-date information on vaccine appointments. So this page is more for reference to check out the different links. If you haven't registered, just a reminder to do so. And we also have the toll-free number at the health unit to call if you're having trouble with the online booking system. And don't see it on the slide here, but it's 1-844-780-0202. And the people who pick up the phone there will be able to help you book your appointment. And that's the last slide for the presentation. And maybe we'll just open it up to questions.
Okay, now, Matthew, did you have anything that you wanted to add, or did you want to try fielding some of the questions that I'll be posing?
I think Chris did a great job for that presentation. Thank you, Chris. I'm happy to help with the questions, though.
Okay, great. Okay, so I have a number of questions. First one, recognizing that after 12 months, we are currently in our 3rd and worst wave, how do you see the pandemic playing out?
So I'm happy to take this one, Chris, if you'd like.
Sure.
I think that, we're at a point in the pandemic now, we've been dealing with it for over a year. We've kind of learned a bit about the ebb and flow of how the pandemic has gone, especially coming down off of this 3rd major wave in the pandemic. We are at a point where we have periods of lull where we're able to resume some periods, some of our normalcy, and then enter other periods where transmission increases because person-to-person contact is increasing, and that forces us to then implement some measures. The province has its lockdowns or shutdowns or stay-at-home orders. And I think we're at a point now where everyone's getting quite sick of the back and the forth and all the restrictions that have been in place, quite understandably. I'm hopeful because this is different. This third wave that we're in right now there's a number of reasons that it's different from the previous waves, but the key thing to point out right now is this is the first wave in the pandemic where we've really been able to deliver a lot of vaccines during the wave and hit some of those critical thresholds for people being vaccinated in our population. And I think there's a growing acknowledgement that the vaccines have made a difference. We've seen the vaccines completely change, for example, the outbreaks that we used to have in long-term care and retirement homes. They were much less of a feature during the third wave than the second wave. And as we're moving our way down to younger age groups, immunizing essential workers, we're also beginning to see the impacts of the vaccines there, quite fortunately, because they are effective. And my thought and my hope, my expectation is that this wave, if we're able to stay in sort of our stay-at-home mode for a little bit longer until transmission comes further down, cases come further down, and until we ramp up our vaccines a little bit beyond where we are right now, it may be the last of the major waves, because by the time things increase again down the road, we might have enough people in our community immunized to blunt the impact of transmission. All this is to say that, you know, where we're going to go, I think, is very much in our hands. The things that we do right now, the choices all of us can make right now can help buy our health system time to get the current wave down, to really smother that transmission as best we can, and to give some time for public health units to get vaccines into arms. I think if we're able to get cases down and vaccines into arms and keep doing the things we're doing right now, then we are going to have an easier summer and hopefully an easier fall and winter to come later this year.
Thank you. Second question, I understand the vaccines have different efficacies. Can you explain efficacy in simple terms?
I'll do my best because it's a bit of a different concept than we usually talk about. But essentially, whenever vaccines are being developed, the vaccine manufacturers bring people into clinical trials. And the clinical trials, what they do before the vaccine's being widely used, to help the manufacturer show that the vaccine works and that it's safe to use. When they build the trials, they have people who they enroll, and usually half of the people get the vaccine and half the people get what they call a placebo, which is a fake vaccine, a vaccine that usually is just some salt water. And the idea is that by comparing how people in the vaccine group do versus people in the placebo group, you'll be able to measure how impactful that vaccine is. And when the manufacturers run these trials, they look at how often in the vaccine group do people get COVID-19, and how often in the non-vaccine group, the placebo group, do people get vaccine. And the efficacy is a number they calculate that reflects how much difference there is in the rate of infection between those two groups. And there's a calculation you can do to determine that, and it's based upon the people who are in those trials. We've been fortunate that for all the vaccines that are currently approved, they've had really good efficacy numbers. And in particular, they're particularly strong when you think about their ability to prevent severe illness, hospitalization, and death. There have been some differences in the actual efficacy numbers for each vaccine. There's some subtle differences there. And in many ways, those reflect the fact that the vaccines were tested under different circumstances. The trials themselves were built differently. They were done at different times, done in different places. And so there are differences, but they're not really meaningful differences when you think of the grand scheme of things. I think the bottom line for all the vaccines is they are all effective at preventing illness. They're all effective at preventing hospitalization. And most importantly, they're effective at preventing death. And so really, any vaccine that's being approved by Health Canada and that we're offering is a vaccine worth taking.
Thank you. Number 3, speaking on variants. I fear the new variants, and I hear they are easier to transmit and some are more dangerous. How can I best protect myself from them?
So the variants are something that have been a more recent aspect of the pandemic, and they've been a big part of why we had a third wave this spring. We do know that the variants, there are several of them. There are, of course, a number of them around the world, but there are several that are important in Canada and in Ontario. And the most important one is the so-called UK variant that we've been dealing with and now accounts for a majority of our cases across the province and a majority of our cases in WDG. And that variant is one that is more easily transmitted, as Chris mentioned. And unfortunately, it does cause more severe illness, which is why we're seeing people in ICUs at younger ages than we used to in the previous waves. Fortunately, with that variant, the vaccines we have seem to be quite effective against it, which is a big plus because it means that those vaccines are still going to make an important difference. I think it's worth, like for all of us, it is sobering to look at the impact the variants have. It means we still need to take the pandemic very seriously. And one thing I can say is that even though the virus has changed, and that's what the variant is, it's a change in the virus, it's still fundamentally the same kind of virus. It's still something that's transmitted in droplets when you sneeze or cough. It can be transmitted if you touch your mouth and then touch someone else. It can be transmitted in these fine aerosols in the air. The fundamentals of how COVID-19 spreads from person to person are still the same, even though it is more transmissible. And what that means is the things that we've always been talking about, things like wearing a mask, physical distancing, washing your hands, staying home if you're feeling ill, getting tested if you're feeling ill. All of those things we've been doing over the entire pandemic are still going to be our mainstays. And of course, vaccines are going to add to our protection as a community. We do need to be that much more diligent and more stringent with our measures because of the fact that the variants transmit more easily, but there isn't anything new that we're asking people to do beyond those things we've been talking about for a while.
Okay, you touched on this next question, but I just want to make sure that I understand the answers. Do vaccines work for these different variants that we are now seeing in our area?
So the short answer is, in general, yes. There is a fair bit of nuance there if you want to dig into it, and scientists are still learning more about some of the emerging variants and how the vaccines perform against them. What we know is that for the most important variant in Ontario and Canada, that so-called UK variant, B.1.1.7, the vaccines seem to be quite effective against them. There are other variants that are much less important to us locally, about which there are some questions about the vaccine's performance, and there are some studies that are constantly happening to help us understand how the vaccines perform and whether there's any change in the effectiveness when it comes to those variants. And we are concerned about the possibility of there being variants against which vaccines are less effective. And we know that the vaccine manufacturers are also looking at the performance of their vaccines against variants, and there's the option and potential for them to modify and update their vaccines to help cover variants as they emerge. The vaccines all contain bits of genetic code from the COVID-19 virus to help train our immune system, and they can modify that if the kind of genetic code of the virus itself changes. So there may be a bit of back and forth as vaccines are updated if there's a need for it. But right now, I can say the vaccines available in Ontario do offer good protection against the most important variants.
Okay, thank you. Some people are reluctant to receive vaccination, mentioning that vaccines are developed too fast, trialed too briefly, lack a long-term follow-up, and have possible side effects such as shingles and sometimes fatal cerebral venous blood clots. What is your response to these vaccine hesitancy concerns?
So I would say even before COVID-19 was on our radar, I think vaccine hesitancy was something we're quite familiar with in public health. We deal with it usually with the measles vaccine, the flu vaccine, and other vaccines that have been around for a lot longer. And we certainly understand, given how new COVID-19 is, given the newness of the COVID-19 vaccines, people have questions about those vaccines and they want information they can rely on and trust about something that they're putting inside themselves. What I can tell you is that when it comes to those vaccines, of course, they have been developed quite quickly because of the urgency of the pandemic, but they haven't skipped any of the safety steps or any of the review steps in the process. Usually when a vaccine is submitted for approval by Health Canada, there's a number of steps that Health Canada goes through with manufacturer, and they happen one after the other after the other. And there are delays, and there's paperwork, and there's reviews and meetings, a lot of stuff that goes into the process, and it can be, to be honest, a little bit slow. What happened during COVID-19 is that because everyone recognized the urgency of getting vaccines to end the pandemic, Health Canada adjusted its approach to go through those same steps, oftentimes in parallel. So they're reviewing data as it's coming in and having conversations at different points in the process with manufacturer simultaneously to enable them to get through all of their safety checks on a much shorter timeline. And of course, they would have more resources allocated to that review process because of the fact that COVID-19 is so pressing. So the vaccines are safe. I spoke before about how effective they are. We know they're incredibly effective at preventing those most serious forms of illness. But we know that people still, they want to hear from someone they trust. They want to hear from public health. They want to hear from their community leaders. They want to hear from their doctors or nurses who they trust. They want to hear that the vaccine is right for them and that they should take it. And what I can tell you is that in our view, having seen the data, having read the product monographs, having understood the impact these vaccines can have, getting a vaccine is the right step for everyone in our community who is eligible to get a vaccine. It will offer them protection. It will protect their families, protect those around them. And once we get enough people in our community immunized, we're going to see a meaningful impact on spread. And once that happens, we can begin returning to our post-pandemic normal. It's going to be really challenging for us to keep up with the measures that we've been doing for the past year. And I think vaccines are the hope on the horizon that are going to get us out of this. And fortunately, we have a number of vaccines available now that are all effective, that are all safe. And if you had asked me at the beginning of the pandemic where we would be in the spring of 2021, I would have never believed that we'd have so many vaccines available that are all effective and all safe. So we're very fortunate in that sense.
Okay, thank you. If I've already had a shot or even both shots, should I do something differently than previously? And can I still carry and spread COVID?
So to answer the second question first, when the vaccines were studied by the manufacturers in those clinical trials I mentioned, they looked mainly at the ability of those vaccines to prevent illness. They didn't look as much at the question of whether it stops transmission between people who may not have symptoms. However, since vaccines have begun to be used, if you think about jurisdictions like Israel or the UK, where there are pretty high immunization rates, there have been some studies done there that help us understand that these vaccines also can reduce transmission between people. It's not just about reducing illness, they can also help stop person-to-person spread. And that's critically important because it means that once we get enough people in our community immunized, it's going to allow us to return to normal. Right now, we're getting a lot of questions about if I've gotten one dose, if I've gotten 2 doses, what should I be doing differently? And our best advice right now is to keep doing the same things you've been doing. And there's really some nuanced reasoning behind that, but to kind of put it briefly, when we think about the impact of vaccines, we think of them in 2 different ways. One is the impact of the vaccine on me if I got it and my own personal risk and the risk of those around me. And the second impact is at a community level, if we get vaccine rates as a community up, what are the changes to what the risk is as a community and the kinds of things we can do as a community? What I think we're going to see is that once we get higher levels of community uptake, more people in our community who have the vaccines, we're going to be able to make some changes to those community level restrictions. But right now, when it comes to individual level things like wearing a mask and physical distancing, we are asking everyone to keep doing those things until we get more people in the community immunized.
Okay. Would you be willing to take a question from Councillor Nix?
Yes, please go ahead.
Yes, Matthew, you've talked about this several times. When we get enough people vaccinated, we can go back to normal or almost normal. And I was curious, because I look at your website almost every day, that you've had this, in your slides tonight, you have this target of 75%. That's not me talking. But my assumption is that that was based, when the initial pandemic occurred, we thought if we got something like 75% of the population vaccinated, we'd reach what they call herd immunity. Now, my understanding is with these variants of concern, is that that's changed the calculations quite a bit, and that in fact herd immunity might not come until we're much higher than 75%. So my question back to both your charts, which show the target of 75%, and your statement several times now about when we can get almost back to normal or back to normal. Have you revisited that target level?
So I would certainly agree with the premise that the variants have changed the calculus, and there's a lot of uncertainty right now about exactly what that herd immunity threshold is. And with a more transmissible form of COVID being dominant in our community, it means we need more and more people immunized before we truly hit that herd immunity threshold. That is something that is being discussed not just locally, but across the province as we kind of consider what all the intersecting pieces are with the public health measures and which ones can or should be relaxed at what various points in time. We have our own target. I know our dashboard and our slides say 75%, but really our target in our minds is 100%. We want to get as many people immunized as possible, and that 75% was developed when we launched our immunization campaign, but it does not mean by any stretch that if we get 75%, we're gonna, clean our hands and say, okay, pandemic over, back to normal. We want to get that number up and up, higher and higher. Part of the reason is because of that more transmissible variant being a factor, but the other piece is that we know that even if we hit a herd immunity threshold as a community overall, say that threshold was 75% or 80%, and say we hit that as a WDG community, we know that that would reflect an average, and there'll still be pockets of our community that haven't hit that threshold. And if there are pockets in our community that are below that threshold, transmission can still occur. And we want to be well above whatever the threshold is that science tells us we should reach, because it's going to mean that we're not going to have as many pockets where there could be spread ongoing. So I guess the short answer is there's not a clear number that we can say with certainty this is the threshold, but we're aiming for as high as we can, and we're working with some of the best scientific minds in the province to try and figure out as a system what makes sense. I'm not sure if you saw a couple days ago, the government of Saskatchewan announced sort of its, I'm going to call it the off-ramp to the pandemic, and they actually had in there some stages of their return to normal, and they were linked to different levels of community immunity. And I think that our gradual reopening, when it comes, which it will, is going to be linked to our targets as far as how much of our community locally, how much of our community as a province is immunized. And so that's going to be an important measure of the level of risk that exists, and it's going to be something that helps us determine when it's safe to reopen. And it might be a bit of a roundabout answer. I hope that addresses what you were wondering about.
No, that was very useful. Thank you.
Thank you.
Okay, so it's now recognized that there's significant COVID-19 transmission by breathing infected small droplets that are present in normal breathing. What is your advice about how best to use masks and the preferred type of mask to prevent this aerosol transmission?
So just to go back one moment, we know that the most important way that COVID-19 spreads is through essentially the droplets of moisture coming out of your nose, your mouth, when you're doing things like coughing or breathing or sneezing. There is, in principle, the ability for it to transmit on surfaces or the ability for it to transmit in other ways, but by and large, the most important thing is person-to-person transmission through those droplets. And we know that some droplets, they are what we call large droplets. They typically fall to the ground pretty soon after they leave your mouth or your nose. And other droplets that are smaller, they can stay suspended in the air. And that's what we mean when we use the word aerosol. They're just small droplets that can travel further than the large droplets. Both of those kinds of droplets can be blocked by wearing a mask. And we've been talking about masking as a health unit since, I believe, at least June. And wearing a mask whenever you're near other people significantly reduces your risk of passing it on, and it also does something to reduce your risk of getting COVID if they have it. And so that's why we mandated masks in a lot of different spaces in our community, and we've seen the impact of that. We've seen that practice taken up across the province and around the world. We know that wearing something that covers your chin, your mouth, and your nose, those are the most important things. Should form a good seal over your chin and mouth and nose to make sure that those droplets and aerosols have difficulty escaping. And Health Canada now recommends that it be made of at least 3 layers, just to offer some additional protection over other masks. Those are the most important characteristics of wearing, those are the most important characteristics of masks if you're going to wear them. But we know that if COVID is being transmitted through these droplets and aerosols, masking is just one part of the puzzle. That's why we're also talking about things like physical distancing, because if you're 2 meters apart, it's that much more difficult for some of those droplets to travel that far and hit one person from another person. We talk a lot these days about the importance of spending time outdoors if you can, or spending time in well-ventilated spaces, because you know that the better the ventilation is in a space, the harder it is for COVID to pass from person to person in those aerosols, the harder it is for COVID to accumulate in the air. And again, opening windows, going outside helps reduce the risk further beyond wearing a mask and beyond physical distancing. So there's a set of interlocking measures that you recommend that all address that reality of droplet and aerosol spread. Masking is one of them, but it is a very important component. And the key things are, for most settings, just wearing something that covers your nose, your mouth, and your chin, wearing something that's made of at least 3 layers, and of course, cleaning it when it's dirty, handling it properly. All of those things are important as well.
Okay, thank you. There's been a lot of negative things about AstraZeneca vaccine, including dosing errors on the initial study, manipulation of data, blood clots in women, and lower rate of efficacy when compared to other vaccines. What is WDG's position on administering this vaccine?
So I'll certainly agree the AstraZeneca vaccine has gotten a pretty bad rap over recent weeks and months, which I consider unfortunate. It's unfortunate because it's a vaccine that is actually quite a good vaccine. It was probably the most important vaccine in the UK when they were able to get themselves out of an incredibly large winter wave, and now to a place where they're well on the way to reopening and returning to normal. It's a vaccine that is effective. It's a vaccine that does prevent hospitalizations, does prevent deaths. And as I spoke about earlier, it's difficult to compare some of the numbers of efficacy because these trials are different, but the key thing is we know it's an effective vaccine. One of the things we have learned about this vaccine, and this also applies to the new Janssen vaccine, the Johnson & Johnson vaccine, is that there is an important side effect that people do need to be aware of when they get it, and that is this really small risk of a significant blood clot. There's this complication, it's called the BIT, vaccine-induced immune thrombotic thrombocytopenia. Big medical words, but essentially what it means is it's a vaccine-linked blood clot that for some people can make them fairly sick and they need to go to hospital for it. Fortunately, it is quite rare. We're still learning about exactly how rare it is. There's different studies looking at quantifying that, but it is a very rare side effect. And overall, Health Canada deems this vaccine a safe one to use. And I would certainly have no problem recommending that vaccine to anyone in our community. You might have heard a lot of media recently about the National Advisory Committee on Immunization, NACI. That's the national body that makes recommendations about how we use vaccines. There's been a lot of play about the remarks made by the NACI spokespeople to media, but I do want to mention some of the work they did in their analysis of the vaccines. When they go through their analysis, they actually talk about, for these vaccines that have this blood clot, the risks associated with the blood clot versus the risks associated with COVID. Because we know that COVID can cause blood clots, COVID can cause pneumonias, COVID can cause a whole bunch of things, including, of course, death. And in their analysis, they actually looked at and compared the risks and benefits of, the vaccine versus the infection that the vaccine prevents. And they look at that under different assumptions and different kinds of transmission scenarios. And what they say in their analysis is that in places in Canada where COVID is being transmitted at a high level, which it is in Ontario, in which it is in WDG, in which it is in Dufferin, the benefits of getting that vaccine outweigh the risks of that vaccine. We continue to say that it is worth getting the first vaccine you're offered because as a community, if you don't have that vaccine, if you're waiting for the next vaccine, that means you're not protected. And that means you're susceptible to getting COVID from someone else who has COVID. So there's a nuanced conversation. It's challenging, and it's difficult sometimes to communicate all the factors that go into these vaccine recommendations. But I think the bottom line is that we are recommending people take the first vaccine they're offered, whether it's Pfizer or Moderna or Janssen or AstraZeneca, and the timeliness of that vaccine and getting it sooner outweighs any considerations about the differences between different vaccines. They're all good, they're all effective, and they're all considered safe.
Okay, thank you. And the last question. Last year has been a grueling one for the healthcare workers and public health staff without a clear end in sight. The community depends on you being able to continue to do your jobs. How will WDG staff managing with respect to burnout and managing their mental health?
Thanks for that question. That's actually a question I'm really glad to have asked. I know that our staff have really put in an incredible amount of work. I feel really proud and privileged to be able to work with the staff we have at the health unit. It's been incredible to see the people we work with step up and deal with this new challenge and deal with the new ways of doing work remotely, deal with the stresses of managing big outbreaks, managing complex cases. It has had an impact on our staff, and as one of the senior leaders in the health unit, it's something that I'm incredibly grateful for. I know also that it hasn't just been our staff. We know that COVID-19 has impacted people across our health system and across our society. And while our staff have made sacrifices, we've also had people working in our hospitals make sacrifices where they've had to work incredible hours, deal with incredible pressures, put themselves at risk of COVID-19. We have essential workers working in places like our supermarkets and our manufacturing plants and all these other settings that really can't close down during a lockdown. And these people go to work every day because our communities depend on them. And they also are making incredible sacrifices to get us through this pandemic. And so while we certainly are bearing a lot on our shoulders as a health unit, we know that we're not the only ones and we're part of a broader community effort. What I can say is just speaking with staff over the past few months, I know that our staff have really, really, really appreciated the ability to play a leadership role in the rollout of the vaccines. Dealing with the COVID-19 pandemic means dealing with a lot of negativity. People become ill, there are outbreaks, people are unhappy with the restrictions, and there's a lot of negativity that has been associated with the pandemic. But the vaccines have been such a positive experience for the staff who work in our clinics. And we do have all of our nurses rotating through our clinics so that everyone gets a chance to contribute to that effort. And I keep hearing from our staff that after everything they've been through, it's so nice to be able to help someone get out of the pandemic and be part of the solution, and instead of just being part of managing the problem. And that has been a real boon to our staff. And I've seen more smiles on faces over the past couple months than I saw in 2020. And while we know there's going to be a significant mental health impact on our staff that we're going to have to manage once the pandemic winds down, I can say that being able to be involved in the vaccines has been a huge help. And our staff are so pleased to be able to serve the community in that way.
Okay. We do have a question that's come in advance from Marion Heron. Marion, are you still online? I thought I saw, yes, she is. Marion, would you like to ask your question regarding the second dose of vaccine?
Yes, I know that some of the other health units, Peel and some other people over in Aurora, when they got their first shot, had their second date given to them. And when I got my first shot, I was not given that date. And Wellington-Dufferin doesn't seem to give out that date. So I have no idea when I'm supposed to get my second shot. So I was wondering if you could clarify why some units are able to give their second appointment, but I'm not in Wellington-Dufferin.
Thanks, Marion, for that question. That's a good question. I know that right now there is a delay between the first and second doses, which I can talk about a bit more. In general, I'm not sure necessarily why you weren't given a date and time for your second shot. I actually, if you don't mind, would like to take that back to my team just to follow up to see if there's anything that we have about that we can make sure we can communicate to you. So if it would be okay with you, I would like to give your name to my team and allow us to follow up just to make sure that we have a plan for you to come in for your second dose. There is some uncertainty about exactly when second doses will happen, in part because of the uncertainty around the vaccine supply. More generally, there has been a recommendation that's been adopted across Ontario that we delay the second dose of the vaccines for up to 4 months for most people in order to allow us to get first doses into more arms. Up until recently, and to some extent still, we're at a point where a second dose in one person's arm means a first dose isn't given to someone else. And we've seen modeling to say that it's actually more impactful and provides better protection if we can get more people with that first dose as opposed to getting second doses. That being said, with more and more of our community getting their first doses and more vaccine supply coming in quite soon, I think we're soon going to be at a place where we can begin bringing people back in for their second shots. And it might be a fair bit sooner than that 4-month window, depending on exactly when you got your first dose. So Marion, I would like to take your information back to our team just to understand exactly when we're expecting you to come back for your second shot. Because even though there's some uncertainty, you want to be able to give you something to hang your hat on.
Well, but when would, how would you notify? I mean, I guess that's the point. I was told that it would be July sometime. I had mine March 30th. And how do I get that information, or how does anyone get that information?
So in our registration system, do you know if you gave our team your phone number?
Yes, absolutely. They had all my data.
Okay. In that case, we have a team of staff who is responsible for managing the phones when it comes to contacting people about their vaccine appointments. So we would be able to contact you by phone with details about the timing of your second dose.
Is that the same for everybody though? I mean, is that how you notify everybody for their second shot, that they all get phoned or they all get emailed, or what's the protocol for getting people to get their second shot? I guess that's my main concern.
So Chris, I might look to you to see if you want to jump in with anything to add, but we have the ability to follow up with people with details about their second shot.
Yeah, so all the particulars about all of our clients who are getting vaccinated, we have in the COVAX system. And so when it reaches the 4-month mark, we'll start inviting people in for their second doses. So end of March, we're looking into June, July. It could be sooner based on the vaccine availability, but the concept is getting as many people vaccinated with at least one dose is a means to protect a greater percentage of the community. And when our vaccine allotments were relatively low, that was really the focus, to get as many people vaccinated with one dose, hence the delay for 4 months for the second dose. Now that we have a line of sight into May with a vaccine allotment increase, with an anticipated increase into June and July, I would expect those second dose appointments will be happening early on into June. And so anybody in the system, in the COVAX system, who's had a shot or who is registered will be contacted for that second appointment, whether it be through email or by the phone, depending on the means that they were registered with.
Okay. Fred, next, you had a question?
Well, maybe it's just been answered, but Marion, you're not unique. Neither my wife and I got our shots, and I've got the form right here, and it says right at the bottom, your next dose is scheduled for, and it's blank. It didn't tell us, but I was assuming, right, just as you answered, Chris, that you'll send me an email.
Of course, and my form says the same thing.
Yeah.
Your next dose is blank.
Yeah, so what we're trying to do is to make sure people who come in for their first dose, they are told about when to expect a second dose appointment. So if you got it, for example, in March, then 4 months from March will be July. People aren't necessarily going to get a specific time and date because there's uncertainty about that. And we're hoping that people are going to come in sooner than 4 months, but we aim to at least let people know what the longest possible delay could be and when to expect to hear from us.
Okay, we have a question from Richard Baird. Richard?
Can you hear me now?
Yes, we can.
Much better. So first, Matthew, Chris, and all your colleagues, thanks so much for all the hard work you guys have put in for the last year and a half. It's been brutal, I know. And my question is more sort of an overall question. And I don't want to, by asking it, I want to make sure that everybody understands. I'm not trying to minimize the impacts and losses we've all experienced, but hasn't this really been more of a dress rehearsal? Because evolution, it does some great things, it also does some really nasty things. So couldn't it just have easily been something with, say, the transmissibility of mumps and the fatality rate of MERS? And if that had happened, it would be a real disaster. I'm just wondering, and then the second question to that is, don't we need to treat this in some ways as a wake-up call to put far more stringent monitoring and preparation and everything else in place?
I think that's an excellent question. I think that the short answer is yes, there needs to be a wake-up call to us as a society about the danger that pandemics can pose. I think one of the challenges of pandemics, and in some ways it's a microcosm of the challenges we face more broadly in public health, is that when things aren't happening in front of us all the time, we don't think about them. A pandemic doesn't happen very often. We haven't had something like this for a century, since the Spanish flu in 1918. And when pandemics aren't front and center, as a society, we don't think about them so much. Certainly in public health, we've been thinking about the possibility of a pandemic because it's our job to, but in the general community, we don't think about it. And that means that we're not necessarily as ready for the possibility of dealing with it as we should be. And while we dealt with COVID-19 right now, it's transmitted this way, has this transmissibility, and has this kind of impact on people's health. The next pandemic, which we don't know when it's going to come, could be something that transmits differently, could be something that transmits more easily, could be something that has more deadliness to it. And the nature of pandemics is that we don't know what to expect. There are things that we can do as a scientific community to try and guess what the next pandemic might be, but we have to be prepared for anything. And I do think there are things that we can do as a society to make sure we're prepared for the next pandemic. And I anticipate that when the pandemic, winds its way down, there are going to be, a lot of opportunities for reflection about the pandemic as we experience it right now. It's just as one microcosm of that, we all, of course, were horrified by the impact that COVID-19 had in our long-term care homes. And, that led to a commission being struck. They delivered their report last week, and they had some concrete, actionable recommendations for government about how we can make sure that a pandemic never impacts long-term care homes like that again. And I think it's going to be opportunities like that for us to find the ways to improve as a system, to make sure that we are always ready for the possibility of a pandemic, no matter what's causing it.
Thank you for that. So we've come to the end of our questions, and I just want to reiterate to Chris and Matthew that we really appreciate you taking the time to provide us with your background, and it's been a great 3/4 of an hour. I hope it wasn't too long for you, but because I know you're probably doing Zoom meetings all day long. But we really do appreciate you coming in and giving us your personal knowledge and views on the situation that we are in at this time. And we wish you good health and lots of success. I see there's a hand. Is that?
Yeah, I just, one final last question. Matthew, could you give us some indication of what percentage of immunity there would be? Let's say I got the Pfizer vaccine or the Moderna or the AstraZeneca. Do you have a number, approximate numbers on first vaccines and then on second vaccines?
So there are some numbers out there that we can kind of estimate from either the clinical trials that were done or from real world studies in places that have been using the vaccines and then done follow-up measurements of the populations. For example, we see that with the Pfizer vaccine, that is one where after 2 doses, you're looking at about 95%. But if you look at people who are more than 14 days out from their first dose, you can actually measure something in the high 90s, depending on which source you look at. So there are some uncertainties about exactly how much protection you get after 1 dose in a 2-dose schedule, and there are sometimes different numbers depending on where you look and how you measure and which population you use. But while we know that the effectiveness or the protection offered by a single dose isn't going to be as good as 2 doses, we are still seeing some pretty good numbers for some of those vaccines, at least in some of the studies. And it seems like the further out you are from your vaccine dose, the more protection you seem to have. Public Health Ontario, which is our provincial public health agency, this week they actually put together a report that they released looking at the risk of having COVID-19 infection after getting the vaccine. They looked at all the examples of people who were diagnosed with COVID-19 after getting either 1 or 2 doses, and they actually were able to produce a really interesting chart in their report where it shows that the further out people were from that first dose, the fewer and fewer and fewer people there were who got infected with COVID-19. And it seems to drop off quite a bit after 10 days, drops off a bit more after about 14 days, and then after about 28 days. And the longer out you are from that first dose, the more it seems your immune system responds to the vaccine and offers you some protection in the interim until you get that second dose. And we have reason to believe that one of the important things about a second dose is not just about offering you a bit more protection, but it's also about making that protection last longer. And we do want to make sure that we have the protection of a first dose in the interim, but the idea is to get everyone a second dose before that protection wanes.
Thank you.
No problem.
All right. Thank you very much, gentlemen. And we do, again, appreciate. Ralph, did you have anything in closing that you wanted to say? Your microphone?
Got the answer. It was about the AstraZeneca, and it was what was Wellington-Dufferin-Guelph's position on administering this vaccine. As far as I can see, it hasn't been used. I may be mistaken, but I think in the vaccination clinics have been using almost all about the Pfizer.
That's correct. So in our mass immunization clinics, either the ones we run or the ones that are run by partners, we've been using mostly Pfizer and to some extent the Moderna vaccine. Those are vaccines that really, I think, work best in those settings because of the requirements around storage and handling. And the advantages of the AstraZeneca are that that vaccine can be stored in a typical vaccine fridge and stay stable at those fridge temperatures. So it's the kind of vaccine that is much more amenable to being delivered in primary care offices, being delivered in pharmacies, and that's where the AstraZeneca vaccine has been delivered in our community. It's been through primary care and through pharmacies. And that's just kind of taking advantage of the characteristics of that vaccine. And we've been making sure that vaccine is being used where it makes most sense, and then using the Pfizer and Moderna in our mass immunization clinics where they make most sense.
Okay, so thank you very much, gentlemen. And we are going to go on to part 2 of our meeting, which is open forum. We do have some pre-submitted questions that came in advance. Anyone who's online and wants to submit something through the chat process or whatever way that you can, we would like to be able to hear your questions. So we have a first one that's submitted by Joe Wilson. Why has the town of Mono not updated its noise bylaw number 2004-16, which identifies with outdated provincial guidelines dealing with the sound levels from stationary sources to current ministry guidelines, which was done approximately October of 2013. So I guess I need to have Mark Early give us a quick synopsis, or is it Dave Trotman that's going to answer?
I defer to my good CAO, but I mean, I think, all of our bylaws, of course, generally are subject to ongoing provisions or updated provisions. We haven't been really targeted to do this at this point in time, but I understand the nature of the question, and there's an updated provision 300 that would supersede, I think it's 232 and the 200, I got that right, per our section 4 of the bylaw. We can bring that back to council. We can certainly take a look at that for sure.
Okay. And okay. Thank you, Joe. Next question is Carrie Holland. What's being done to address the increase in crime, light pollution coming from dealerships, Fieldstone in the Fieldstone subdivision? Is a traffic light going to be installed on the second line, Highway 9, to relieve the traffic coming from the businesses on French Drive? So where are we with the illumination of the second line and Highway 9? And I guess it's Mike Dunmore might be able to give us an update, unless Mark Early wants to.
So Your Worship, a preliminary report was prepared by R.J. Burnside, which took in traffic counts and so forth. And at that time of the report, the draft report states that there's no current warrants. However, the town has left it inside of our current development charges study. I would like to ask the person, I guess, some more questions with respect to her need, with respect to the second line lights and whether they are for industrial traffic, commercial needs, or whether they are residential needs coming from the first line area. We would recommend that the first line area utilize the first line stoplights that were installed as part of the development, and to avoid the commercial area.
Okay, thank you. And Deputy Mayor John Krulman, would you be able to make comment about increased crime in that neighborhood? Are you aware of any rise over the last couple of years?
Well, it comes and goes, and it's somewhat better now than it was some time ago. But it is on our radar. It is an issue that comes up from time to time at the Police Services Board. We try and encourage the OPP to conduct patrols in that vicinity, and we're on top of it as much as we can, but it's certainly not gone unnoticed.
Okay, thank you. And in regards to the light pollution, we do have all of those dealerships under our dark sky lighting requirements. So, Mr. Early, did you have any other comments on that?
No, any site plan that does come in with the commercial facilities down on 9 do go through a lighting review. It's a mandatory requirement for our review procedures. We do ensure that all lights are full cut off and that there is no light trespass from those properties. So I'm not sure whether these are whether we're dealing with buildings that haven't come through the site plan process that are causing the light pollution. I haven't driven by there at night for a while, so that's the only explanation I could see, or because the lights are being assessed on every site plan approval.
Right. Mr. Trotman?
Yeah, just to reiterate, that's true. I mean, any site plan application that we have, the photometric review is part and parcel of our overall review and submission that we request from an applicant. And our good engineers Burnside do weigh in on that aspect of site plan review, and they're very diligent with it as well. So, yeah, anything that's come through more recent review has had a photometric review and compliance to that effect. So,
Mark?
I'm just going to add, it's also being along a provincial highway. It's also a mandatory requirement and part of the submission to the Ministry of Transportation.
Okay, so to prevent damage to property, or?
No, the ministry's requirement is to ensure that there is no light trespass or glare onto the provincial highway system from any lighting that's put in on any commercial facility along a provincial highway.
Okay, thank you. And Mr. Simpson, do we have the email address for this question?
I will double check. I'm not sure off the top of my head if we do or not. Everyone was asked to submit a means of getting back to them.
Right, okay, so if you can possibly draft something for Mark's review to make sure that we're answering questions. Yes, Deputy Mayor?
I'd also point out that there is an enormous amount of light spilling out from the antiquated lighting installed by MTO on that stretch of road. And I believe that issue is addressed by a letter that we have sent and refreshed over the years to the Minister of Transportation, requesting a number of changes, and so far absolutely nothing has happened. There also may be some legacy lighting in that vicinity as well, but I think most of the dealerships have at various times over the past 20 years converted to full cut-off lighting.
Right. Okay, thank you. Next question from Anthony Hoseen. Speeding and road condition issues with Mono-Angela Town Line. An ongoing issue with no plan of action in sight to putting mitigation plan in place to address speeding concerns and issues with the quality of roadways, i.e. poor road conditions. Now, I know this comment had come through from previous council meetings. Deputy Mayor, at Police Services Board, has there been any discussion on the patrolling of Mono-Angela Town Line to, I guess, even if it's the 20th, from 89 down to the 20th?
Yes, we have discussed it, and we've discussed it from the context of it being a joint effort of the two OPP detachments. Obviously, the Dufferin detachment and the detachment to the east. I don't know what has been done, but the question and the problem has been raised a number of times.
Yeah, okay. So potentially you could have that on a future meeting so that we can have an update. In terms of, thank you. So in terms of the poor road conditions, I know that this resident has asked for updates. In other words, I think pavement was one of the things discussed initially. Mr. Dunmore, do you have any comments regarding this?
So as council is aware, in 2012, I submitted a draft roads and needs study. It outlines some particulars as to what the Public Works recommendations would be to council for road upgrades. And it also outlined what the triggers for these upgrades would be. And those are, council has been very frugal with their budgets and very proper in setting up the budgets and are moving in a pace that's being recommended by the Public Works Department. With respect to the poor road conditions, the gentleman has not really identified what the poor road condition is. I missed his presentation, I believe, in early or late 2020. But we do attend to road conditions as required, and we attend to the potholes per the minimum maintenance, and we attend to these as required when a gravel road does receive potholes and washboards and so forth. And final point is the town line. I'm not sure exactly where this gentleman lives, but from 89 30 Side Road down, we are now experimenting with the limestone crusher run, and we'll be continuing further down the town line, and we're having great success with that.
Okay. And so, in order to respond to Mr. Hoseen's comments, would you be able to draft something of a response with Mr. Simpson to this question so that we can reply to his concerns? And also to mention that the Police Services Board is working with the Easterly detachment to try and monitor that area more closely. Is that possible?
Absolutely, and unless council has any objection, I've added this to our solar radar speed sign, and we'll take a look at that data.
Okay, great. Thank you.
Thank you.
Next question, Trish Kichi, who is online. What can be done about the extremely noisy motorcycles on Hockley Road? And I'm sure that Deputy Mayor Creelman would love to tackle this one.
Well, the motorcycles are probably the hardest vehicles to actually apprehend. the OPP is very aware of the situation on Airport Road. It replicates itself on Dufferin Road 8, otherwise known as Mona Center Road, and of course Hockley Road. It's something that we are attempting to deal with. We are upwards in the County of Dufferin of 100 charges for stunt racing a year. And there is legislation before the Parliament now that is attempting to address this. I'm not certain that it does it in a terribly effective way, but we remain vigilant on this. We would love to have automated speed enforcement technology brought to bear on speeders, but unfortunately the regulations are constructed in such a way that it makes it virtually impossible for their application of this in rural Ontario. But thank you for the question. And again, I will go back to the Police Services Board and remind them that this is a chronic problem.
Okay. Trish or Darcy, did you have anything, any follow-up to the comments?
Yeah.
You just had it.
I know. No, not really. It's just the noise is just unbelievable, and I don't know, more noise than speed from our perspective, but they often are one and the same, I guess.
Yeah. Okay. Ralph, did you have something you wanted to add?
I was just going to say this is a problem which we don't have an answer for. We must just let's make it clear. The police will not chase after motorcycles. It's unsafe, and they just don't do it. They're speeding. And there was a trial in Calvin to assess noise, and they had some kind of a noise meter. And I know that they did try and prosecute, and it didn't go through court. So Calvin gave up on it. And first, it's a big problem, and we don't have an answer for it. So do you have any suggestions?
Okay. So I have no further questions that have come in. So at this point, we do have an option to ask for Deputy Mayor Creelman to speak on the internet infrastructure and an update on who we've been able to get hooked up.
Thank you, Your Worship. It's been a busy year from the standpoint of attempting to get the interest of various providers, and our first success came back in November, where a local startup approached us about locating wireless equipment on our water tower. That was accomplished, and they are now signing up customers within line of sight of that particular installation. The federal and provincial governments also came through with very generous grant programs, and we have received at least 3, possibly 4 very specific grant requests that are being considered as we speak by both the federal and provincial governments. Rogers is proposing to lay fiber optic cable throughout the entire town. The Vianet company is proposing some 90 kilometers of fiber optic service within the town. And again, the third and fourth operators are part of the SWIFT organization, which is working in southwestern Ontario. And these are programs that, as I say, are subject to consideration for grant monies. We've organized very successful support campaigns on behalf of each of these providers. Rogers and Vianet tell me that they've never seen such an outpouring of support for an undertaking, and that such support from the community is absolutely critical in getting the attention of the governments. And I'm optimistic that some or all of those applications will be successful, and we'll see the installation of fiber optic, something I never dreamed of, quite frankly, within the next 18 to 24 months within the town.
Okay, Mark?
And John, just to add to John or Deputy Mayor Creelman's comments, there's the fourth company is V Media that council's granted support to, and they're looking at kind of a hybrid between the two. They're looking hopefully at fiber in the ground, but also before they get there, subject to funding, they're also looking at line of sight as well throughout some portions of the municipality, including the water tower.
Okay. Great news. Thank you, John. Ralph, you have your mic on. Did you have anything that you wanted to add? No? Okay. So now, Ralph, you were prepared to speak on the parking enforcement that we've instituted in the recent months.
Yes, I'd be glad to. Particularly with the advent of COVID, there's been a great increase in the number of visitors to parks from within and outside of Dufferin. And this has created some problems, particularly at the Mona Cliff Park. As most of you know, the main parking entrance is on the third line, north of the Mona Center Road. And last fall in particular, we had people parking on the road as the parking lot there had filled up. And they were parking on both the right and the left sides of the road. And there was room for one line of traffic to go down the road for about a kilometer. So it was a very bad safety situation. And council decided that they had to do something about it. But the second problem that came up, and this was pointed out to us by many of the users of the park, and there's a lot of people in Mono in general and Mono Center in particular who have a great love and appreciation of this park. It's a unique park ecologically, and it's a natural heritage that we really want to protect. And what was happening was that we were having a massive increase of people that were visiting the parks, and the number of people, not only an increase of people, but the way the park could be used. In the park, people were going off trails and were leaving a lot of garbage and degrading the park. So what the council decided to do was to try and deal with the parking problem and try and get the number of people going there to be managed. In many parts of Ontario, park volumes are managed often by the internet, and you sign up to enter the park for a certain period of time. We don't do that here. Everybody who can get on the trail gets a chance to walk the park, and the park just can't handle that. So what the council has done has instituted no parking, and we've also instituted a discussion with the park wardens, and hoping that the park warden and the organization will come around to identifying that the parks can only handle a certain number of people, and then they start to get degraded. So we have put in no parking on the third line, up above and below, north and south of the third line parking area. We've put in no parking on a portion of the second line, because that's the second access for the park, and also up on the 25th line, because there's an unofficial access up there. Our bylaw officer has been active. This has happened since the beginning of April. Our bylaw officer has been very active on the weekends there. And we're also going to fund a second part-time bylaw officer, and the park wardens have also will be able to issue tickets. So in the last 4 weekends, we've issued 120 tickets. I think the word will get out that you can't park there, and this will help to not only handle the lack of safety on the road, it will help to decrease the number of visitors in the park.
Okay, thank you, Ralph. So at this point, anybody who's logged in, would you like to ask any questions of council that may not have already been asked?
It's Marion Heron. I'm just wondering, is there anything more that we can do to try and stop this Highway 413? I know you've written letters, but is there any more campaigns, or is there anything more we can do as citizens to try and stop this?
John, since you did craft the motion and put it forward, would you like to make some suggestions?
Marion, thank you for raising the issue. I introduced a motion to council which they supported that condemned the concept of the 413 and it built upon wording that was passed by Orangeville Council and I believe other municipal councils. Subsequent to that, the federal government has come out with a statement to the effect that they are going to launch an environmental assessment of the 413 project, which is rather unique, frankly, that the federal authorities would do so. They've got good grounds to do so from the standpoint of the impact on the environment. All I can say is I think we all have to remain vigilant and we all have to remember that this is going to have a tremendous impact on our community in as much as all Caledon roads lead north. They will be dumping cars from the 413 onto Caledon roads, which is an issue that they're going to have to address. And many of those vehicles are going to end up on Highway 9, which is not ideally designed for even the volume of traffic that it currently experiences. So I think we just have to keep the pressure up.
Okay. So any other questions? Yes. Your mic.
There you go.
Yeah.
I wasn't, since things are winding down, I wasn't particularly going to mention this, but I just wanted to advise council that the three neighborhoods, Watermark, Cardinal Woods, and neighbors to the west of the Dufferin North, Peel Anglers and Hunters are still waiting for an application from them. And just to mention that we are still watching the noise for noise studies and consulting with an acoustic engineer, and likely will be in contact with the Ministry of the Environment, Conservation and Parks at some point. So thank you for your attention on this matter, and we'll go forward from here. Thank you.
Okay, thank you for that. Okay, so as we're at 8:30 and I don't see any other questions and I have nothing in the chat room. Mr. Simpson, have you received anything?
No, there's nothing in the chat room that hasn't been addressed.
Okay, thank you. So I guess we're closing early, and I look forward to comments from anybody who has been watching on video broadcast, and to see if they enjoyed this format better. And so we can go ahead and schedule another one possibly in mid-fall, and hopefully the word will get out. So with that, thank you everybody for attending, and wish you a good evening, and we will reconvene council next Tuesday at 7 p.m. Thank you.